This is one of the regular twice-a-month cardiac pathology conferences held here at the National Naval Medical Center. The general routine for these conferences is that we have 3 or 4 heart specimens, and as a rule I examine these specimens as unknowns, and after examining the specimen attempt to predict the patient's age and sex and a few general items regarding clinical information about the patient. I like to do it that way simply because it makes me at least look harder, and secondly I think some of us as pathologists are often pre-prejudiced as to what we may or may not find at necropsy by previously reading the clinical record. The first specimen here has been opened already, obviously. There's many ways to open hearts. It's always a personal, no two people open hearts the same way. No two people examine a patient exactly the same way either, I guess. No two people operate precisely the same way. I'm sure that if I opened this heart initially, I would have opened it differently. But the positive or intriguing items here is number one, that there's a lot of subepicardial adipose tissue on the surface of this heart. The adipose tissue always surrounds the coronary arteries, and the coronary arteries, in essence, reside in this soft, foamy bed of adipose tissue. I think this fat protects the coronary arteries from the underlying beating, contracting myocardial wall, so it may have a good influence. On the other hand, the atherosclerotic plaques, to some extent, look like the subepicardial adipose tissue, and I have an impression that if we were dealing in groups of 100, that adults over 50 with the largest proportion of subepicardial adipose tissue would also have the largest numbers or amount of atherosclerotic plaques. I go to one of the charity hospitals in this community, and the amount of adipose tissue in general over their hearts is considerably less than present at most of the private hospitals in the city. And I think that the amount in general of atherosclerotic plaquing in the coronary arteries of those individuals with relatively little subepicardial adipose tissue is quite a bit less compared to those with a lot of fat. The same analogy might also be made with patients with fatal neoplastic disease. Often there's atrophy of their subepicardial adipose tissue, and in general their coronary arteries are relatively clean. The same might even be said of patients who died in World War II in concentration camps. As I understand it, the amount of coronary arterial luminal narrowing by atherosclerotic plaques was relatively small in those individuals dying of starvation for practical purposes. Possibly a little periodic starvation would be good for all of us. The positive findings in this particular heart are 1, left ventricular hypertrophy. Number 2, there are no foci of fibrosis or necrosis. In other words, obviously there's no scarring, and there is no obvious dead muscle. The 4 cardiac valves to me appear normal. There's really not much to see from this viewpoint. The coronary arteries have been taken off the heart, I presume intact, and that is an excellent way to examine the coronary arteries. This is the way that I like to do it at any rate. Now, how much luminal narrowing? Many of these arteries the lumens are quite wide open. I think when anyone sees a heart which has no scarring in it, no necrosis in it, and the coronary arteries have been examined in detail, one certainly has to be on the alert for so-called sudden cardiac death as the cause or mode of death. In general, however, the degrees of luminal narrowing of coronary arteries in patients dying suddenly, so-called sudden cardiac death, is about the same as in patients dying of acute myocardial infarction. Now here, of this segment of about 7 or 8 centimeters long, there's only one segment of 5 millimeters or so that has any luminal narrowing of any significance in it. And the lumen here, I would judge between 51 and 75% narrowed. The lumen is, the residual lumen is eccentrically located. I don't know if you can see that. For example, if this be the coronary artery and this the medial wall, the atherosclerotic plaque shown here in white is like that, so that the residual lumen is eccentrically located. I think that's probably advantageous because when there is pressure in there, this can expand somewhat. Whereas if you're dealing with an artery that has a central lumen, and all of this is atherosclerotic plaque, which is usually relatively firm, it's far more difficult for that lumen to expand compared to an eccentric plaque. I think this is the anterior descending coronary artery that I've been examining here. I don't consider any luminal narrowing of less than 75% of great significance. Or in other words, it's extremely unusual for someone with fatal ischemic heart disease, whether it be sudden cardiac death or sudden coronary death. There are many causes of sudden cardiac death, but what we're talking about is sudden coronary death, or fatal angina, which is relatively infrequent without previous infarction or a sudden demise. In other words, most patients who die of angina are put in the category of sudden cardiac death. It's very unusual in any of those individuals not to find 2 of the 3 major coronary arteries narrowed greater than 75%. Now these arteries here, I'm not positive which ones are what. I think this big one here is the left anterior descending, and it's a very dilated vessel and relatively wide open. So this is not easy. The positive findings here are: 1, there's left ventricular hypertrophy. There's narrowing between 51 and 75% of one of the 3 major coronary arteries. That's all I can tell here quickly. And the remaining, and that's focal, and the others are wide open, and they're also quite sizable, very dilated. Number 3, there's no fibrosis or necrosis of myocardium. 4, there is no ventricular dilatation of either RV or LV. Now this is not the usual situation in somebody with cardiac death. The 4 valves are normal. I presume that this is hypertension at one time. But I don't, there's no floppy mitral valve. There's no, there's a lot of fat in the heart, but a lot of people have that. There's no communications, no shunts. I'm at a puzzle to say that this is a cardiac death. I think I'm going to need some help here. I don't think this is I think this is a patient that I would say this is most likely a man, that this person was maybe 45 or 50. But I don't see a cause of death here by examination of this heart. What's the story?
Okay, well, this was not a cardiac death. This was a 46-year-old white male active duty captain who was in good health until he had a sudden collapse on the 12th of this month. He was brought to the hospital. A cerebral angiogram was done, and a left frontoparietal mass lesion was seen. He had a craniotomy, and a hematoma was evacuated. We have no history of hypertension in this man, other than in a 1969 physical examination he had blood pressure of 138/88, and his blood pressure on admission to the hospital here in September of this year was 180/100. I think the question was...
Now that's after he had the increased CSF fluid.
Yes.
Pressure.
The question is, does this demonstrate a hypertensive heart to fill in that 5-year gap that we have no blood pressure readings on?
He was a Navy man, I
Yes,
presume?
active duty.
And there are no pressures
Not
way back?
all
no
normal.
Available pressure?
All normal prior to 1969, and in 1969 it was 138/88. That's the last recorded pressure prior to his admission. We have a 5-year gap in pressures readings.
This fella kept healthy, or was he obese?
He weighed 230 pounds, was 6 feet 2 inches tall. That was his weight in 1969 as well.
And he died of a CNS hemorrhage,
Right.
the etiology of which you're uncertain of. Did you see a ruptured aneurysm?
No, we haven't really examined the brain, but nothing was seen grossly immediately. The brain has not been cut.
I mean, nothing was seen on the surface of the brain or in the circle of Willis?
No.
But it hasn't been cut through and through?
No, it hasn't.
Well, and the heart weighed how much?
480 grams.
Weighed 480 grams. And he never had evidence of cardiac dysfunction, never had chest pain at any time?
Nothing that's documented in his health record.
So if you've got a man who's 46 and has a CNS bleed and there's no mass lesion in the brain, the chances are overwhelming that that's a what?
Aneurysm or focal atherosclerosis, I suppose.
Focal atherosclerosis? You mean narrowing?
Yes, I suppose. Those would be my two choices.
Well, that's a big difference. One, you've got a so-called aneurysm, and number 2, you have an obstruction. Now, the key, the thing that's the situation, as I understand it in this patient, was that when you tapped his CSF fluid, the pressure was increased and it was bloody. Is that right?
Well, he did not have a spinal tap. He was operated immediately.
And what was found?
Intracerebral hemorrhage.
Intracerebral. That is within the substance of the brain.
Yes.
So an intra-brain hemorrhage. You know what a lacuna aneurysm is? Lacuna infarct?
No.
I think that if we take all of intracerebral hemorrhages, that is within the substance of the brain, that if an individual did not have hypertension, that he would not or she would not have an intracerebral hemorrhage. In other words, if we could do away with hypertension, we would do away with intracerebral hemorrhages that were not the result of trauma or brain tumors or something like that. But the run-of-the-mill intracerebral hemorrhage, in my opinion, is a hypertensive lesion. Now, what allows that judgment? Well, number one, certainly the majority of these patients have a history of hypertension. The majority do. Now, those that don't, so often, their initial time that they ever went to a doctor is when they had the sudden clinical catastrophe. Secondly, that if you take patients that have intracerebral hemorrhages, you're going to find cardiomegaly. Now, how do you explain cardiomegaly in the presence of 4 normal valves, no lung disease, no significant coronary arterial luminal narrowing? How do you explain it? When somebody is 41 and has a blood pressure of 140/90, what are the chances at age 46 that it's going to be greater than 140/90? The chances are pretty doggone good, aren't they? Do you ever rupture a berry aneurysm without hypertension? Or are berry aneurysms congenital or the result of increased pressure in the arteries? Well, there's a lot of debate on that, I gather, but I guess the general thought is that the arterial wall is weakened congenitally, but it's the increased pressure that allows the expansion and finally the rupture. Most CNS hemorrhages are consequences and complications of systemic hypertension. And if we could do away with systemic hypertension, we'd do away with most CNS hemorrhages, obviously excluding trauma and the rest. Now, how big a heart can you have that's be normal size in somebody who's 6'2" and weighs 230 grams, 230 pounds? How big is Manny Sistrunk's heart? It's got 270 pounds. What do you consider within the range of normal of somebody that has huge muscle mass? Does the heart mass increase in the same proportion to striated muscle mass elsewhere in the body? Why shouldn't it? If 40% of the blood that comes out of the heart goes to our muscle structure, if you increase the muscle structure, you have to increase the muscle mass of the heart, do you not? And somebody 230 pounds is 480 grams within the range of normal? I bet a lot of this fellow's increased weight was adipose tissue. There's certainly a lot on his heart. I would think certainly more than should be there for somebody only 46 years old. I think the biggest thing that doctors can do from a cardiovascular standpoint in this country, that is one of the affluent so-called developed countries, is treat hypertension. We're not so good treating coronary disease, let's face it. Shunts, VSDs, ASDs, pretty good treating that. But the biggest killer is hypertension and coronary disease. And we don't know yet whether lowering one's blood lipids will decrease the amount of atherosclerosis. Presumably it will. But the evidence is overwhelmingly clean that if one lowers his or her blood pressure, that the complications, namely the CNS complications, the hemorrhages, some sudden death, abdominal aneurysms, dissecting aneurysms, all that stuff, frequency would disappear and would diminish enormously. Other comments or questions? Hypertension is the most neglected entity from a health standpoint. I don't think there's any doubt about it. I get the heart from Suburban Hospital right across the street every month, a couple of big pails of hearts. I'll tell you, it's hard to find a normal size heart. What's a normal blood pressure? That's debatable. Maybe the hearts in 1974 are simply bigger than they were in 1920 when all those numbers of so-called normal came about. Maybe that's possible. But I have a suspicion it's the blood pressure that's going up. How many folks here have taken their blood pressure in the past year? I took mine about 10 years ago, and it was 110/60, and I thought I was going to live forever. And I took it last year, and all of a sudden it was 135/85. Well, that's normal. But the complication rate from an increase of systolic pressure simply by 25 millimeters is a heck of an increased risk. That's a risk going up, increasing risks of all these things we discussed by 20% right there. I started getting one of my colleagues to take blood pressure during the day, or my blood pressure during the day, and come in and it'd be 120/80, have 3 cups of coffee, and it'd be 140/90. Go to 3-4 places like this in the daytime, and it'd be 140/90. If I stayed at work all day long, it'd be 110/70. There's no question that there are tremendous influences on our pressure. I get 9 hours sleep at night, come in, blood pressure is 110/70. Get 3 hours sleep, and the pressure is 140/90. Taking these random blood pressures that I gather you folks do, a patient comes in and take the blood pressure, and it's either normal or abnormal, and that's it. That's a pressure at that particular time, and it may vary enormously under certain conditions. Maybe all of us have a little elevation of pressure. We're just not aware of it. Maybe it's best not to be aware of it. I'm a little uncertain about that. But I'm convinced of one thing, and that is that our arteries were made for a certain pressure, and that if it's too much, they dilate, they obstruct, or they pop. And the coronaries obstruct. The aorta is less likely to obstruct because it starts out with a bigger tube. It's more liable to dilate, fill with clot, pop quickly or pop slowly. Dissection, no question, is a hypertensive disease. Eliminate hypertension, and there's no question that dissecting aneurysm is gone. That's purely a complication of inadequate therapy. Well, the next heart here has left ventricular hypertrophy. This is septum. It's thick. This, I believe, is posterior wall, and there's a transmural scar here in posterior free wall. The anterior wall looks okay. This scar extends from the apex all the way to the base posteriorly. In other words, if we draw this out, posterior wall is thinner. Let's say this is anterior and this is posterior. Posterior is thinner because there's a lot of scar in it. This is the anterior leaflet, aorta here. If we draw a section across that transversely, the posterior scar is not so big. It does not take up a. This is the ventricular septum, anterior wall. This is RV, and this is posterior. That scar does not occupy a lot of the muscle mass of the LV, but it does actually protrude out some here. So you've got a little dilatation of the posterior wall in that area. I mean, it's a little aneurysm. It's small. I suspect it would protrude out just slightly bit more with left ventricular angiography. Now, to have a scar that goes all the way from base to apex, basal, mid, and apical portion of posterior free wall is a pretty sizable infarction. Here in this posterior scar, which also involves the palp muscle, it's scarred, there's a lot of fat in there. See, that's soft right there. And here's a person, again, a lot of fat on the surface of the heart, covers the right ventricle entirely. If this patient walked across the street in 1900 in Baltimore, Maryland, and collapsed and died, and the patient was taken to Johns Hopkins Hospital, and autopsy was done, this patient had been signed out as a fatty heart. No question about it. Fatty heart was the way that patients were labeled back at the turn of the century of those who died suddenly. Now, this patient, I presume, also has cancer. This is the RV, and there's a little tumor nodule right there. It's black inside. Is that melanoma? Well, the black, I predict, would represent hemorrhage in the center of that little tumor nodule rather than melanotic pigment. And there's a little RVH. I would tend to think that this fella had more than one problem. I would say that this individual had hypertension, had old myocardial infarction, which was quite extensive. This led to LVH. And he had cancer. Just playing the odds, I would bet on lung as the most likely. But that's a bet. If you take all comers of cancer in their heart, the most common is lung and breast. Men, it'd be lung, women, breast. If you go by percentages, it's melanoma first, and then leukemia, and then lymphoma, and breast and lung a little further down the list. I would think that this person was about, golly, not too old, about 50. I'd say this 50-year-old man. And he probably, this was his, he had a myocardial infarction and probably did okay after that. The LV cavity is not too big. I suspect he did not die from a cardiac death, that he lived all okay with this transmural scar, but that cancer is the thing that caused him to cross the river. What's the story?
Well, this is a 64-year-old gentleman who did have malignant melanoma.
Malignant melanoma. Gee. Okay, malignant melanoma, not multiple myeloma. Okay. And he had myocardial infarction.
Yes.
At what age?
2 in 1961 and 62.
He had 2 of them. These are continuous with one another. I just saw a heart before I came over here. They had 2 scars. One here, then they had a separation, and then another one. That patient only had one history, clinical evidence of myocardial infarction. Now here we see one where it's just one continuous scar, and he had two. Okay, so in 1961, huh?
Yes.
Okay, that's 13 years ago. That's when he was 51. He had acute myocardial infarction. And what else?
Well, one in 62, which wasn't as bad. He's, since that time, in 1965, he started throwing a few PVCs and was placed on quinidine. He's been maintained on that since then.
Okay. And what happened?
Well, this gentleman had some cerebral metastases. He presented with a mass lesion on the right. They operated and did a decompression frontal lobectomy, and he died in his post-op course.
And so from a cardiovascular standpoint, his last 9 years of life, he had no evidence of cardiac dysfunction.
Simply a recurrent arrhythmia. The arrhythmias did crop up during his post-op course, but probably it wasn't the main problem he was having. He was having primarily CNS-like problems.
Now that's from his brain metastasis.
Yes.
But from a cardiovascular standpoint, until this terminal event, he had no evidence of cardiac dysfunction. Is that correct?
That's correct.
So he's in the pretty small odds. He's gone now 13 years past his first MI, 12 years past his second, and from then on he was perfect. Do we know what his blood pressure was prior to age 51?
Prior to age 51, probably it was normal, because the earliest readings I see in the chart are somewhere in the early 60s, 1963, and it was somewhere in the neighborhood of 125/70. However, readings in 1973 were 190/90 in the right arm and 165/100 in the left arm. But on admission, this past admission, it was 122/84. And the chart simply listed it as him having mild hypertension, not on any medications for the hypertension, but somewhat well controlled.
Well, this is a very exciting case, really. It goes against all the odds. If you take the natural cures of hypertension, what are they? Well, one is acute myocardial infarction, and he didn't have any hypertension to cure, so that didn't do him any good. Another cure of hypertension is cardiac amyloidosis. It's incompatible to have severe amyloidosis and elevated blood pressure. And I've seen some patients with elevation of pressure, and then it gradually decreased, and they died, and their heart was loaded with amyloid. Those two can't go together. Ever seen constrictive pericarditis associated with systemic hypertension? Constrict that pericardium and you do away with hypertension. Hypertension, you have a central factor and a peripheral one. And if you clamp on that central one, there's no way for the periphery to clamp so much that it still elevates the pressure. And here's a fellow who has a pretty sizable posterior wall infarction, extending all the way from the base to the apex, and yet he's got enough muscle left to go from a pressure of 120/70 to 190/90 following 2 myocardial infarctions. Now, you're not going to find many patients that have that history. If you take the majority of patients that have myocardial infarction, their blood pressure lowers thereafter. But there are not many examples, at least in my experience, where a person has 1 or 2 myocardial infarctions and then 10 years later it's found that their blood pressure is quite sizable. Now, could this have been central nervous system created hypertension? Well, I doubt it, because there's considerable LVH here. How much did the heart weigh?
The heart weighed 410 grams.
That's LVH, though. How much did he weigh? 110?
No, he weighed 200 pounds.
200, man. And he died of malignant melanoma. Wow. Okay. I don't think all the heart's here on this patient. This is J. Pierce.
No, that's it.
This is it, huh? That's his problem, then. Well, this fella, it's hard to demonstrate this, but he's got calcium right here. Now, this is the non-coronary aortic valve cusp right here. This is the right, and this one is the left. But right at this junction, there's a nodule of calcium. Right at this junction is where the AV bundle is. And this is the type patient that, okay, that's non-coronary cusp, the right. This is the membranaceous septum right there. That's the anterior mitral leaflet. And there's a nodule of calcium. And this is where the AV bundle is, right there. If you look at that from the other side, that calcium is at the posterior medial commissure. And as I understand it, in patients with mitral stenosis, if you're going to have calcium, it's most liable to be on that posterior medial commissure than anywhere else. You'd agree with that, wouldn't you? This is the type patient that might present with complete heart block or left bundle branch block. An elderly individual. There's calcium up here at the so-called sinotubular junction, and there's also calcium beneath the posterior mitral leaflet. I don't know if you can see that or not. That's in the so-called annular region, mitral annulus. The LV is not dilated. I can't be sure of any. Didn't have gas gangrene or something, did he? See, there are pits. There are pits in this muscle here. I thought first they were probably artifacts, but I don't think they are. He didn't have infection, this fella, did he?
Yes, he had quite a few bouts of pneumonia.
Well, I'd say this is an elderly individual. I'd say 75. And that he may well have presented with complete heart block or left bundle branch block at any rate. Can't be positive looking at that, but that certainly may be the situation. I don't see anything in his heart, quickly looking at it here, that would be an explanation of his being examined right here. These things that I see in the LV free wall also present over here in the RV free wall, so I wonder whether they're real or not. I would think of infection here, and I would wonder about that at any rate. But I'd say this fellow, this 75-year-old man, whose death cannot be attributed to cardiac disease per se. What's the story?
Well, this is an 80-year-old white male who was in the hospital for complications of hip fracture and implantation of a hip prosthesis. He has had long-standing severe chronic obstructive pulmonary disease.
Is she man or woman?
A male.
Okay. She is a male.
She is a male.
Okay.
And had severe complications of an elderly person with in the hospital for for a hip fracture and had several bouts of pneumonia and died a pulmonary death primarily.
So what did you see in the heart?
Basically, it looked like there was hypertrophy of both RV and LV a little bit. They looked thicker than the heart. In other words, they looked too thick for what the heart, for the size of the heart.
How much did she weigh?
130 pounds.
What did the EKG show?
EKG, there were several traces, but there was, on one trace, a question raised about right ventricular hypertrophy, but this person had a normal sinus rhythm. Also, there was mention of poor R-wave progression.
Well, I don't see any definite scars in the heart. Blood pressure was what?
Blood pressure at one time was 200/90, but this person was on Oretic, which is an antihypertensive, and the blood pressure during this admission was 130/60.
So that's hypertension too. May well be all three patients probably had hypertension, right? What we call normal may not be. It's probably average. But there was no left bone branch block, no complete heart block.
No. He suffered from heart failure as well and was on digoxin, if that's any help.
Gosh, I can't believe heart failure there. There's no cavity dilatation. Okay, so we've had three patients. The first patient had a CNS bleed and had LVH. And there was plus or minus hypertension, and the man was only 46, right? The second patient was 64, had two healed myocardial infarcts 12 and 13 years earlier, and other than a few premature ventricular beats, the last 13 years there was no evidence of cardiac dysfunction, and his blood pressure progressively increased. So this patient had hypertension, probably. This patient had hypertension. The third patient, 80-year-old man.
Yes.
Had hypertension and lung disease. A smoker, I gather?
4 packs per day for 20 to 25 years. He
So
stopped in 1964.
If you've got an elevation of pressure, if you've got a 190/90 pressure in the systemic circuit, what is it in the pulmonary artery? If you have emphysema also.
It's probably much elevated if you have the fibrosis.
Okay. Thank you very much. Okay.